Good morning, everybody. It looks like it is right at 10 o'clock Central, so we'll go ahead and get started with our provider audit webinar. So today we have quite a few topics to cover, and the timing has actually worked pretty well because, we have the inpatient proposed rule that came out a while back. Actually, the comments were just due a few days ago, so we have that came out, and we also kind of had a surprise or a surprised final rule come out for the Alina. I just refer to it as the Alina Medicare Part C days and how they're impacting DISH, the SSI ratio specifically. So, initially that was just going to be an overview, kind of a, hey, here's what we're still waiting on. We don't really have anything, but now obviously it's turned into a last minute, here's the final information. So, a lot of good information. Hopefully, you find it informative. So, the first thing I wanted to mention is just a few housekeeping items. The recording, basically an email will be sent out within a few days of this meeting, including the recording of this, or a link to the recording. It'll be on the YouTube page. Obviously, the recording itself would be far too large to send via email, but it'll be a link to the YouTube video for the recording, a copy of the PowerPoints, just in case anybody attends that did not get the initial email. So I'll send the PowerPoints again. I'll send an attendance certificate and a copy of the agenda for the same reason. So you should see that here within a few days of the meeting. It takes a little while to touch up the recording and get it onto YouTube. Also, just a heads up, I'll mention up front, and then I'll mention it again at the very end. But we have a new way of handling the surveys. I think this is our second webinar with this new survey. So there are two different ways to access this survey. We have a link, and then there's also one of the QRS codes. So we have that down there. You could use either one, and I certainly appreciate any feedback you have through the survey. And for the agenda, so we are going to be covering S10 uncompensated care audits, give a little status. Now, obviously, the last webinar we had last quarter was focused solely on S10 audits. We're not going to go into anywhere near that level of depth. We're just going to give an update. I want to point out a few things, and this kind of leads us into the template for S10 as well. And then the next topic right after that does cover the cost report documentation templates. These are new ones we've posted to the website, so we wanted to point those out. I will mention that we do have YouTube videos covering each of those individually, so I'm going to point those out. We'll just spend a little bit of time going through the template here, but again, the YouTube video goes into a lot more detail. Then we have a new, what we're calling the audit rate or claim information page. I want to point it out and I want to show a mock-up. We don't have the final page ready to go. I was hoping we would have it ready by the time of this webinar, but it's not quite finished. We're adding a few new things in there. So I just want to point out, let you know what it's going to look like. We'll spend some time going through the 2024 IPPS proposed rule. There were a few things to point out there, so we'll talk about that. And then we're going to spend quite a bit of time talking about DISH, as you can imagine, especially with the new Alina final rule that came out. We will talk about a few things related to GME. And then just very briefly at the end, we're going to go through an overview of the resources we have, the website, the webinars, and the YouTube training resources. Now, as far as questions, if you have any questions throughout the webinar, feel free to post them into the chat area. I can see that on one of my monitors, and we can answer those questions along the way. So with that, we'll go ahead and get started. So for S10, the worksheet S10 uncompensated care audits, this slide is more informational than anything. It shows where we've been from the beginning of S10 up until basically until last year for this slide. So you'll notice the first couple of years we audited a sample of providers, and there were some issues with that. CMS, really providers also wanted that to be expanded. So starting in 2020, we audited 100% of Now, again, the history just shows, what year we're performing the audits, what data we're reviewing, so what cost report periods we're reviewing, and then when that data was used or when it's proposed to be used in some of the later years. So if we go down here to 2020, these are the ones we performed in 2020. This was the first time we started the 100% of dish eligible providers. Now that data was used in the fiscal year 2022 rates. But what I want to mention is that data is also being used for a couple of additional rates. The factor 3 of the uncompensated care payment, it's being used for a couple of different years. There was a change that actually happened last year where they proposed to start using an average of data instead of just 1 year at a time. They started averaging data. They started with a 2 year average, and that's basically where this 18 comes into play. It's used as half of the average for the fiscal year 2023 rates. And then for fiscal year 2024, which of course is coming up right now, that's what the proposed rule is all about. They're proposing to use a 3 year average now that we have enough data to do that, enough audited data. So they're using 18, 19, and 20. That's what's being proposed for the 2024 rates there. So I just wanted to point that out. And you can see that carries forward. And you'll notice they started this average when we started auditing 100% of the providers. That's the reason for that. Again, this is just more informational than anything. Here, if we move to this year, the audit's being performed in 2023. We are again auditing 100% of dish eligible providers. We're currently auditing the fiscal year 21 data. So cost report periods beginning between 10/1/20 and 9/30/21. Now, what I want to mention there is that if you have a you had a short period somewhere or maybe a long period, so you have 2 different years beginning between 10/1/20 and 9/30/2021, the requirement for us is to take the longest of those years, and that's what we're taking a look at there. So we're not merging the data, we're not reviewing both years, we're taking the longest of those years, and that's the data CMS will be using to calculate the factor 3 of the uncompensated care payment. Now, again, assuming they continue on this 3 year averaging, then we kind of expect, now this is not even proposed yet, but we expect that they will use 1/3 of this data as the factor for fiscal year 25. Again, that'll come up next year. That's just our assumption at this point. Who knows? They could change it. So the other point I wanted to make there, again, with the dish eligible hospitals, that's the requirement. If you look at the Federal Register, we're reviewing dish eligible hospitals. So right now, that is any hospital that is reported dish on E Part A line 34. For most hospitals, most acute care hospitals, that makes perfect sense. The question is, specifically with SCH, Soul Community Hospitals, it really doesn't impact MDH hospitals because they're always going to be paid, the federal rate plus some possible additional amount. With Soul Community Hospitals, though, it's basically a situation where you're either paid the federal rate or you're paid the hospital specific rate if that happens to be higher. So the argument there is that if this Soul Community Hospital historically has been well above the federal rate, then really nothing that happens to Dish, nothing reasonable that happens to Dish would even matter because their hospital specific rate has always been higher. That's the argument that's always been held out. Why bother going through this effort for no real return? And I'll get to that Federal Register statement here in just a bit, but I do want to mention also that if a provider comes through and let's say you did not have Dish when we first selected the universe for the audit, but then, they're usually due by December 31st. So let's say come December 1st, the provider submits an amended cost report. Maybe they have additional Medicaid days, maybe even some Section 1115 waiver days that we'll talk about later on. And maybe all of a sudden now they qualify for Dish. As soon as they qualify for Dish and as soon as we know about it, we now have to go back and start an S10 audit for that provider. Even if it's at the end of the year, even if it's into the next year, CMS does require us to go through that S10 audit process to make sure they have the best data for calculating factor 3. So certainly it'd be best to have that data as soon as possible. So if you know that you need to file an amended cost report to include DISH, and if you have all the information you need, all the Medicaid eligibility days, basically the sooner the better. So now if we go to the point about the sole community hospitals. So uh, there was in the fiscal year 21 final rule. Actually, the proposed rule first. There was a proposal or a question, a comment that was incorporated into the final rule. And this is a quote straight from the final rule. It says, concerning the suggestions to exclude sole community hospitals from audits of S10 when the hospitals are paid under their hospital specific rate, in other words, that's higher, CMS basically said, we note that all hospitals are required to maintain that documentation. And they further say there's the chance that a hospital something might change for whatever reason. Maybe the hospital specific rate was revised, maybe it was audited. There are a lot of things that could potentially happen, but they basically said, of course, the SCH status could change over time as well. That one is very valid. Sole community hospitals may lose their status, which all of a sudden means the federal rate is more important now. So that's basically the reasoning they gave back in 21 for why we still need to audit the S10 for the sole community hospitals. And in the instructions CMS gives us, they reiterate that. So definitely we do have to audit sole community hospitals regardless of what your rate is, whether it's higher or lower than the federal rate. However, the interesting piece about that, they've held that same stance since 21 and really even before then. But now if we take a look at the new worksheet S-10 instructions from Transmittal 18, notably these are effective for cost report periods beginning on or after 10/1/22. I want to point that out, make that very clear. But if you look at the instructions under the template, which we'll get to in the next few slides, but Exhibit 3C specifically, which is it's the total bad debts for S10, but it's also under the charity care for bad debts. The exact same verbiage exists. It says here, if a sole community hospital is eligible to receive a DISH payment adjustment, in other words, they've reported something, but E-Part A, line 48, the hospital specific rate is greater than line 47, do not complete an Exhibit 3C listing. And again, the same thing applies for the charity care. I just happened to grab 3C instead of 3B. So the interesting piece there is for 10/1/22 and after, you're no longer required to submit that template, but that really hasn't said anything. CMS has not said anything about whether we'll need to actually audit that data, which again, that'll come up in a couple of years. One might assume that since they're not asking for the listing, maybe that also means it's going to be pulled out of the audit down the road. But again, that's speculation at this point. We won't know for at least a year, maybe closer to 2 years. So I just wanted to point that out, that it's possible a change is on the horizon. Again, no guarantee though. For this year we're currently reviewing, we absolutely have to review sole community hospitals. So some of the resources we have available, we have the WPS GHA website, or just the WPS website. We have a few different links there. And we also have some YouTube videos. Now, keep in mind, we've also had a variety of webinars that focused solely on S10. Every year, right at the beginning of the process, we do the S10 webinar to kind of introduce everything. But I just wanted to include a couple of links there. So that is what we have for S10. Really quickly, I did want to open up the instructions just to kind of give you the bigger view of that worksheet S-10. I guess that's S-2. Let me get to S10 really quick. I mentioned this in our last webinar, and I mentioned it on one of our YouTube videos. But if you go to the worksheet S-10, you'll notice they've also changed a little bit. There are actually 3 different links related to S-10. The first one is just kind of an overview, gives you some definitions and such. Then there's part 1, which is the hospital and hospital complex. In other words, all subunits, all sub-providers, everything else. Notice that the instructions are not, or the templates instructions are not there. They're under part 2. But what I want to point out here is this part 1 is hospital and hospital complex. This is currently what's being audited. We're auditing all the units. There's a possibility CMS may decide to change that down the road. I think they started to propose it one year that they wanted to focus on the hospital, but the hospital itself, but they decided not to proceed with that. So right now we're still auditing hospital and hospital complex. That's the template we'll be looking at. But if you get to part 2, it's basically the same line. It's the same line, same instructions. It's just for the hospital only. Do not include any of the units or anything else. For whatever reason, part 2 is where they stuck the template instructions. Again, the same template applies to both part 1 and part 2. I don't know why they put them here. One thing I do want to mention, though, that piece that I talked about, the whole if the SEH is the hospital specific rate is higher, that's found in 3B and 3C, same verbiage. So I just wanted to point that out here. Yeah, Debbie, so good question here. If you have a facility that did not qualify for DISH at the time they submitted the cost report, but they did qualify at audit when the new SSI ratio came out, would they go back and do an S10 audit at that time? So it really boils down to whether or not that rate is still even, whether that data is still even being used for the factor 3. And we basically have to work with CMS when we identify those providers. We work with them to see if they want us to do the audit. Is there time for us to do the audit before they would use the data? So the answer is definitely possibly. But when you say 2 to 3 years later, without knowing the fiscal year of that cost report, my guess would be it's too late for that data to matter. And but in any case, we do that analysis. We do run a listing to find out any new provider that has now qualified for DISH that we didn't already audit. So depending on the year and the time frame, we may be auditing that. And if we do, we would send in that, we would send out the initial information request letter. So you don't need to worry about starting it yourself. We would request that up front. Let's see. Yeah, William, good point. Part 1 and part 2. Yes, I'm glad you mentioned that. There is, if you read through the instructions, it does indeed say to submit the template, a separate template for each one. It's kind of unfortunate. It's, again, the same template. It's just that one of them has hospital only data and the other has the hospital complex. So if you, yeah, here it is. Complete a separate exhibit for the hospital and each component of the hospital complex. So that's the unfortunate instruction there. Now keep in mind though, this is 10/1/22 and after, which I guess, we're the current years you're now starting to submit would be close to that, depending on your fiscal year. So yes, we do have to submit those. Good question there. And let's see, there's another question. The instructions for Exhibit 3B state the sum of column 20 amounts for uninsured patients on the charity care listings for all of the hospital and hospital complex must equal S-10 part 1 line 20 column 1. So see, column 6 specifies to enter 2 if the patient was insured but not covered. This bullet specifies the accounts reported on line 25.01 and are reported on line 20, column 2, column 1. Oh, so maybe hopefully I'm getting your question right, but that is a good point there. Anything you see on line 20, or actually anything that's reported on line 25, must also be part of line 20, column 2. So it's not just going to be down there by itself. It has to be up here. So the charges, coinsurance, deductibles, copay, they all would have to be on line 20. Line 25 is just a subset, a potential subset of what's been reported in line 20 under the insured column. Let me just read through your question just to make sure that's what you're asking there. And actually, let me pull up the template. That might make more sense too. Let's see. Oh, and it will kind of, as I'm waiting for this to come up, very good point. If you have no subunits whatsoever, then you're correct. The two listings would be the same. The hospital and hospital complex would be one and the same in that case. So here we have the template, and we have the total charity care template. Now, by the way, this is kind of jumping to the next topic in the webinar, but this is our version of the template we've put out on our website. It incorporates all the requirements from the instructions. We certainly strongly encourage you to use this template just for consistency purposes, but you can build your own template as well, as long as it has all of these same columns and follows all the same rules. So let me go back here. You're saying for column 6. Yeah, this is where you enter the insurance statuses. 1, 2, or 3, basically fully insured, fully uninsured, or kind of partially insured, partially covered. So in that situation there, you enter 2 if the patient was partially insured. And I guess I'm not quite seeing why you're thinking they wouldn't tie. This is just an indicator as to whether it's going to be covered or not. And then what we would want to see over here in the charity care would be whether it's an uninsured discount amount. Is it one of those charity care items, or is it something else? Oh, I get you. So status 2 will go to column 2. Oh, yes, you are right. Column 2 is insured. Yeah, I get you. So that's kind of one of the flaws in how CMS has decided to split those claims. And let me back up here. In a perfect world, in my opinion, again, just my opinion, it would have been a whole lot better for them to say anything that's covered, even if it's just partially covered, goes in insured. Anything that's not covered at all, it's a full charge, goes in uninsured. But they brought in that line 25. They've had that since the beginning, actually. They brought that in. And because of that, an uncovered item, because it's exceeding the length of stay limit, that I believe should go in uninsured, they're saying go ahead and put it in insured. But then this line 25 lets the system know how much of that is truly not covered. So that's what kind of leads to that little bit of that flaw. But I guess the point here is, yeah, you're right, that instruction wouldn't exactly match. There, by the way, there are a couple of other kind of flaws in those instructions that I go into a little more detail in the webinar or in the YouTube video itself. But yeah, you are right that the 2, if you have a 2 status, then since that's going to be in column 2 for the insured, then you're right, that wouldn't tie out to what the instructions have said. So it's one of those things hopefully CMS can change, but yeah, it's kind of unfortunate there. Wish I had a good answer for you for that one. That one just won't quite match the instructions. So, yep. Yeah, thanks for the question though. Good one. And let's see, how is hospital versus hospital complex defined? That would be NPI, or actually more specifically CCN. So the actual provider number, that's how the complex is defined. Basically how you would report it on the cost report. Sometimes that's a separate NPI number, but there might be multiple NPIs for a particular CCN as well. So basically, don't worry about the NPI, worry about the CCN instead. And the RHCs, yeah, those would be part of the units as well. So anything related to the RHCs would be included also. And let's see if we've covered all the questions there. Yep, I think we have for the S10. So good questions for that one. And we might have some additional questions here when we look at the templates next. So let me open this up just to kind of get us to that slide. So going through a little bit of the history here, back in the 2019 IPPS final rule, CMS included or incorporated a requirement to submit a listing at the time of cost report submission that ties to or really corresponds to the amount reported on the cost report. For DISH, although the IRIS data was already required even prior to that, now it just has to correspond to the amount. And home offices, there was some verbiage in there about home offices. We won't talk about those two because those don't really require templates per se. But at that point in time, there was actually no detail as to what the listing needed to look like, other than the fact that it had to be a claim by claim detailed listing. There were no specified fields. So you basically would have to have basic information about that claim and then the amount per claim that was leading to DISH, leading to bad debts, leading to S10, whatever. At that point in time, we posted a recommended template to our website. And this template, I should say, at that time, was created through a work group that included a variety of other Macs and even some CMS contacts. So we took that template, we posted it to our website, again, recommending that you use it, but it was not required. In 2020, August 21st, CMS change request 11644 revised the cost report acceptability checklist to now fully incorporate that and require a rejection of the cost report if the template was not included. Again, the Federal Register prior to that already said that it would be rejected. Now this formalized it. Still no specific template. On November 10th of 2020, just a couple months later, CMS issued their first proposed rule to obtain comments on some proposed templates that they had built. And when I say template, more of a description. It still wasn't an Excel spreadsheet. It was a description of the fields. Then on June 22nd of 2022, they issued a second proposed rule based on some comments they had. The finalization of that is in Transmittal 18 of the hospital cost report form set, which came out back in December of last year. So that's where we are today, and that's what I pointed to with the S10. They now have the templates, and again, that word maybe is the wrong word. They have the instructions and they have the description of what your template must look like. Let's put it that way. So we'll go through this for a little bit here, but I do want to mention this is effective for cost report periods beginning on or after 10/1/22. So some of the cost reports, if you had a short period, you might have already filed one. Otherwise, your that year is going to be coming up for you in the near future. And the instructions are found in different places depending on the type we're looking at. The template for the DISH Medicaid eligible days is found, it's Exhibit 3A, that's the label. It's found at the end of worksheet S-2, Part 1. So the normal control questions for the cost report. The Medicare bad debts, now keep in mind, we've always had a Medicare bad debt template. Most recently, it's been referred to as Exhibit 2. The new version of it is Exhibit 2A. That's found at the end of worksheet S-2 Part 2. That's the cost report, or that's the hospital reimbursement questionnaire. It's not the same as the Part 1, just the cost reporting instructions or the cost report questions, a little bit different. I'll point that out in just a bit. And then we have the S10, both charity care and total bad debts, 3B and 3C specifically, or respectively. and they're found at the end of S-10 Part 2, as I mentioned a bit ago. I'll open up the cost report instructions just to kind of point you there and show you what I'm referring to in a bit. But here's the link to the new version of templates we've just posted. In fact, it was just Monday, I think they got finally posted on the website. I'll definitely open that up. We'll see that. We kept the old versions because we know some providers might be filing amended, or they may still have a cost report to file under the old instructions. So the old templates are still there. Now, that does not stop you from completing the new template, even for those older years. Keep in mind, there were no specifications about what the old templates even needed to look like. So certainly feel free to use the new templates. They are, in some cases, they have more fields to them. So maybe you prefer the old template with the last year that you can use it. That's fine. But both of them exist for now, at least. At some point, we'll remove the old template. We also have the old and new version of the YouTube videos on there. And the thing about it, now that there are specifications, all the fields on those templates are required. But again, you don't necessarily need to use our Excel spreadsheet. You can create your own if you wanted to. So with that, first thing I wanted to do here is open up just each of those templates just to show you what it looks like. So S-2 Part 1, we go to the instructions here, shrink that a bit, and they're usually at the end of that particular set of instructions. Here we have Exhibit 3A, which is the Medicaid eligible day template, and here's what they give you. Again, it's not an Excel spreadsheet or anything like that. It's just a description. Exhibit 3A for the dish. If we go to S-2 Part 2, the reimbursement questionnaire, again, if we go to the very end, well, actually, yeah, the end of it. So here's the original Exhibit 2. Now that's a little hard to read, possibly. The original Exhibit 2, the old Medicare bad debt template that's been around for years. And then right underneath of that, you start off with the instructions for Exhibit 2A, all the different columns. And then here's the new template. You can see it's quite a bit longer than this old template. So we have all of that. And then S-10 we just briefly looked at. Scroll back down there. 3B for charity care. And then 3C for total bad debts. Very similar, just a few differences between 3B and 3C. Now, again, you could create your own templates if you like, but on our website, we wanted to create a template, link to a template that you can use. So let me show you where those are. If you go down here, and by the way, on the link is in the PowerPoint, but it's our main cost report audit guides and resources page. If you go down here under cost reports, you'll see cost report documentation requirements and templates. And if you go to that, here's the new version of the page. There's an overview of the information, links to the various federal registers and change requests, the new information about 10-122 and after, and the on or after 10-122 template and video. But also we link you to the instructions themselves, the ones we just looked at a little bit ago, if you want to build your own template. Same with Dish, same with S-10. Now, again, there's some verbiage about the home office, but there's not a template for it. That's just the home office cost statement that we're talking about there. Who needs to be filed to. So we have that, and I've already downloaded the templates, so I'm just going to open them up there. But again, you can find them right here. So let's start off with we'll go in the order, I guess, the Medicare bad debt template. Now, again, the YouTube video that's out there goes into much more detail. They're about a half hour a piece. We don't have a half hour a piece to spend on it. And the first tab is the instructions tab. And it gives you really everything you need to know, what the columns need to look like, and just how to use the template itself. Now, the way we've built it, we have a tab called the summary. This is not something that's required at all, but this is something we built to help you as the provider and also us when we see this template. It basically links all those different tabs to the various cost report lines that it needs to be reported on. Now, the way this works, you obviously enter your basic information up here about the cost report, and then for whichever of these templates you need, so let's say I have acute care inpatient traditional, I'm going to put an X there. Let's say I have acute care outpatient traditional. Now notice at the very bottom what's going to happen here. A new template opened up. If I have psych inpatient traditional, another template opens up. So it's the X that drives that template. One of them always exists just so you can see the template and see what it looks like, even if you have no X's in there. But all the different X's you put in, it'll open up the template for you, and it'll link it back to this section. So if I open up that template, all of the columns are in the same order. So yeah, this goes to Christine's question. They're all in the exact same order, exact same column number. There are some cases where we add a little bit more verbiage to the label, but it's still extremely close to the label that CMS has used. We just added some verbiage to help explain it further. And what you'll see here is, oh, and by the way, I do want to stress this. For these templates, the total line is in the very first line, which seems different than how you normally build a template. But the reason we did that is so from your systems, you can more easily dump all of the data in, even if it goes to, 100,000 rows, 200,000 rows. We have no way of knowing where your end date or your end line is going to be. So we decided to put it at the very beginning, and that way we can link everything back to this main page. So if I was to, for example, let's see, this is a bad debt. So if I was to put in $100,000 bad debt, obviously for one claim that's ridiculous, but hopefully ridiculous at least. But let's say we have 100,000 there. It shows up in the total line, and it'll also show up over here in the reference here. So that's how that works. And again, all the columns match as far as the column number and what it's looking for. We're in the same order there. The Medicare bad debt template is pretty straightforward. A lot of that stuff up front is patient claim information. When we worked on this with CMS and with the other Macs initially, the thought was that we wanted to help identify whether something was timely billed, for example, whether it met the 120-day requirement. So we put all of that stuff in here. And we also wanted to help show when this is eligible for Medicare write-off. In other words, write-off and reporting on the Medicare cost report. There are a variety of requirements that must be met before that, a variety of dates that had to have happened. It certainly had to have been written off on your internal accounts receivable, so we asked for that write-off. If it was sent to collection agency, it had to have been returned from the collection agency. All other collection efforts must have ceased, including the Medicaid RA. And at that point, once all those requirements are met, you can now write it off on your Medicare cost report. So that's what these additional columns are for. There are some informational only lines. Now, these do not show up on the required template from CMS. These are informational only, and these throw out flags. If based on the information you've entered, it looks like it was not timely billed, it'll show an X here. It'll actually say untimely. If it's a potential 120-day rule collection effort violation, it'll show up there. This just kind of shows you what day could you possibly report it on your cost report. Is that day within the current cost reporting period? And then are your allowable bad debts less than or equal to the Medicare and deductible? Because it makes no sense for them to be above that. That's what bad debt is, coinsurance and deductible. So that's the important information from the Medicare bad debt template that I wanted to point out. Again, the YouTube video goes into much more detail. Let's go to the DISH eligible days template. Oh, and thank you very much for that comment, Harold. I'm glad you enjoy the website there. So now we have the Medicaid days template, and it follows the same basic approach. Obviously, there aren't nearly as many templates you could have for Medicaid days. You have the Medicare hospital, the acute care hospital, and you potentially have a rehab, but the same thing applies. If I put in an X for a few of those, then it gives you those tabs. It even tells you what line and column those need to be reported on, as it does right here as well. Oh, go back here. The instructions are right here. Tells you where it goes, where it's reported, and really what it is, how that day is defined. So slightly different template than the Medicare bad debt. You still have some basic claim information. You have Medicaid days. We obviously need to know the Medicaid recipient number. CMS wants to have the state eligibility code. In other words, in your state Medicaid plan, which of the Medicaid eligibility codes is this claim under? And the reason that's important is that not everything that's paid by your state is truly Title 19 Medicaid that is allowed for DISH. There were some OIG reports a few years back where things were allowed that were, yes, they were state payments, but they were not truly Title 19 Medicaid, and that particular eligibility code should not have been allowed. So we need the eligibility code for this claim, because then we have to do research to compare it to the actual approved or allowable eligibility codes to see whether it's eligible or not. Patient population code, there's a little bit of definition for that over there. So they actually have defined certain codes to use. So I'll just leave that to the instructions there. Which column number was this reported under? Now, this one, because we have the tabs separated by column number, pretty much everything on this tab is going to be column 1, line 24, column 1. Obviously, the days themselves, what type of day is it? What was the insurance? And if that patient was Medicare eligible at the same time or for part of that stay, then we need to see when they started eligibility, when they ended eligibility, because of course, if they were eligible for Medicare for the entire stay, that's no longer a Medicaid day that we can use. So that's the purpose for this. So that's a quick discussion there on DISH eligible. And then we will look at S10 here. Let me open up that. We already kind of looked at it initially. Just a few things I wanted to point out, and then I'll go back to the questions here. So this one, it's not quite the same because you're not going to have, I guess we only have one total charity care, one patient payment, one hospital bad debt. We don't have the same summary tab, at least in this version of it. That may change down the road with the new requirement for having potentially multiple forms filled out for the hospital versus the complex. But for right now, it's just one. So for the charity care, A lot of this is similar to the version that you've been using up to this point, the version we send out. But we have, this was just talked about a bit ago, this insurance status. If you go to the instructions there, talks about how 1 is used if they were completely uninsured, 3 is used if they're completely insured for the entire stay, 2 is if they're partially insured, partially not covered, depending on the reason there. So we have that. What are the insurance plans? And then most of this template is to reconcile the total charges for that claim and identify what I just refer to it as the disposition of those charges. Where did they go? What used up those charges, or what accounted for those charges? Some of them were third-party payments. Some of them were contractual allowances that reduced the charges. There might have been some other non-allowable amounts, courtesy discount, for example. There might have been some patient payments, bad debts. And then the 3 in green here are the 3 different types of charity care we can allow. Uninsured discounts, charity care for the non-covered charges, and then any other charity care charges that are allowable as well. And then T is the sum of those. Of course, the write-off date. So total charity care, I guess the one thing I do want to point out here is that the payments for this column are all payments throughout the entire history of this claim. It's not the same as what's going to be reported on line 22. It's a different thing altogether, but we have that. And then same with the bad debts, the entire history of bad debts for this claim. With the bad debt template, same thing applies for the payments, the entire history of payments. And now, because on the bad debt template, we might be reporting charity care, it's the same thing, the entire history of charity care for that claim, not just what was reported on this particular tab for that claim. It might be charity care from a year that was written off last year, and now the rest of it is bad debt. That'd be the situation here. So again, the templates are covered in great detail in the YouTube videos. I just wanted to give a little overview since we're talking about this topic. But I see we do have a few questions here. Not all states provide this information. Has CMS gone to the states and told them to provide the codes? So that kind of goes back quite a few years with all this Medicaid RA stuff, whether it be for bad debts or DISH. They have indicated they have tried to require states to give that information. I guess you could go to the question of leverage, how much leverage they do have. So the answer is yes, they have, but whether the state is following that requirement or not is a different story. So they definitely have gone there, and we've told CMS the same thing on our side, but I know it puts providers in some states in a bad position. Uh, the only thing we can do is keep bringing it up to CMS and keep trying to get CMS to pressure the state, if that's the right word. S10 requirements and cause. That's the next question here, and that's a very good one. In fact, let me pull out the cost reporting instructions here. And it's odd because S10 has not had an impact on critical access hospitals since EHR, the electronic health record incentive payment, since that went away. When that was in place, then yes, S10 did matter because that was a part of the calculation. That's not been in place for a number of years now. But if you take a look at this instruction, even the new version, it still says, oh, where'd it go? Here we go. Section 1886D, the acute care hospitals and cause are required to complete this work. For the Part B Medicare only, let me get back to that dish template here. This particular requirement was just for if there's Part A eligibility. So let me open up one of the templates here. Yeah, it doesn't really specify here, but it's basically for Part A eligibility. If you just have Part B eligibility, you wouldn't need to worry about that. We're just concerned with whether it's a dual eligible patient or not. Dual eligible in the context of dish eligibility, if you will. So Part B eligibility is not required. Yep. Yeah, Kirk, you're exactly right. The template is not needed for cause. Let's see, column Q. Let me get back to that one here. For S10, the uninsured discount. So it only applies to uninsured or self-pay discounts. You're exactly right. It's just the self-pay discount. They call it the uninsured discount, uh, but it's also known as a self-pay discount. So that's the only time you need to put that in here. For an uninsured patient, just a regular charity care, that would be over here in column S most of the time. And yeah, William, good question there with regard to charity. So the old template used to require the revenue codes. That was one pretty big change they made in the new template. They took those out. In this case, they're not required, and that really added a lot of complexity to developing the template, developing your listing. The purpose of the revenue code was for us to be able to look through and see if there were any professional or physician services that were included, because they're not allowed to be included. That's no longer on the listing, and therefore we can no longer do an upfront review of it. In other words, we can't easily go through the listing and say, hey, here are 10 of them that are professional fees, let's carve them out. So what that means is now it's only going to be found during a sample type review. So from the provider perspective, those are still not allowable. You should still self disallow those, but we can no longer see it up front, so we'd have to find it through detailed testing. And the problem with that is that now all of a sudden it might be an extrapolation. We try to avoid extrapolations. We'd much rather be able to cleanly identify certain things and remove them up front, but we no longer have that ability for the professional fees and physician fees. So it certainly behooves you to exclude those before submitting the listing. Let's see, wouldn't it be beneficial to have prior year and subsequent fiscal year charity and bad debt columns on the S10 template? Prior and subsequent charity and bad debt columns. I guess I'm not quite understanding what you're saying there. Prior year. Oh, you're saying look at the history of that claim to see if they've reported any other charity care in the past. Is that what you're getting at for that particular claim? And if that's the question, I mean, you do make a good point, because there is the possibility. Yeah, you're exactly right. There is the possibility that a charity care might have been written off, part of it last year, part of it this year. And that's a valid point. But the one thing I want to point out here is that this comparison we're doing, we're not always expecting it to exactly equal total charges. The main concern is that these components never exceed total charges. So there might be a couple of reasons why these components, when you add them up, they might be less than total charges. One of the reasons is exactly what you just mentioned. And because if charity care was written off last year, then it's not going to be included this year. So that's one reason. The other reason might be that there's an amount that the patient still owes, but they just haven't paid it. It hasn't been written off anywhere, so it's not going to be included in any of this, and therefore the components are going to be less than the total charges. So certainly a very good point, and that could definitely happen. And let's see here. 17, 19. Oh yeah, 17 through 19 only report what is claimed in the current fiscal year because that's helping us to reconcile to what you've reported on the cost report. And I think that's all the questions here. Oh yeah, Nick, good point. So yeah, instead of completing a new exhibit, if you wanted to include a column to the right, I suppose that would work. We just need to have some way of identifying that it relates to this hospital or this unit. That would work. It's not part of the required template, but there's nothing really stopping you from adding additional columns to the right. We don't want you changing the order of things because that was part of the requirement. CMS defined certain columns, but if you want to add things to the right, you certainly could, or even a comment tab or comment column to the right would work too. Sounds good. So a lot of good questions on the templates themselves, and again, the the YouTube videos go into a lot more detail with that. So now I will move on to the next topic here. And this one is something, again, I hoped we would have it more refined by this point, or actually finished, but it's just not fully ready. So I'm going to go through a little bit of a mock-up, but even the mock-up's going to change. We're trying to identify newer things we can put in there to make it beneficial for providers. But what we have here is we're just calling it it's an audit rate or claim information page. There are certain claim type questions that do come to audit versus our claims customer service. Generally, these relate to things like hospital specific rates for SCH, MDH hospitals. Those types of questions come to us. And our goal is to put a page out on our website that gives you a lot of information, a lot of resources to go through to allow you to find information about the rates if you need it. So the link I have here is just taking you to our overall audit page. And this is a screenshot of where we are going to locate this page once it's ready. It'll be under the cost report rates header, and we're going to try to put it right at the beginning. So the mock-up, I want to open that up here. And I'm just going to spend a little bit of time on it because I'm also going to have a YouTube video once we get it ready that'll go into a lot more detail. But the goal here, it's going to cover a few different things. So wait for this to open up. So our goal is to point you to the various places on the CMS website, or one of our goals is to point you to the CMS website and the various places where you would find the annual rates for the IPPS hospitals, the psych, the rehab, SNF. Now, what you don't see here yet that we're going to add is more explanation on when you get to this page, what do each of those tables actually provide for you? For example, where can you find the wage indexes? Where can you find the cost to charge ratios? Where can you find EHR payment reduction factors, or the flag, I should say? Just all those different things. That's one of the goals here, and that's what's going to take a little bit more time to get to. So we'll have the link there. We'll have more descriptions for each of those. There's also just a pointer to the CMS pricer where you can actually find a lot of that same thing, or a lot of the same things for your provider only. So that gives you some information there, and then also a reference to using the DDE system, and you can do the DRG inquiry screen. We'll put a little more information there. The one thing that's going to be new that we have not had before, and it's not on the CMS website, and well, I shouldn't say that. That's one way to find it, but we actually have a form we're going to link to this that shows you how to calculate, or it calculates your SCH, MDH rates for you. And it'll be attached right down here when it's ready. I'm going to show you what that'll look like, but this is still in progress. There's one big thing I'm trying to add to it. But what happens with Soul Community and Medicare dependent hospitals is that it's the rate, the actual hospital specific base rate. Every so often it gets rebased by CMS, and every so often they tell us just to update it to a new year and lock it in until maybe 4 to 6 years later. So whatever it's locked in at, we always have to update it by the subsequent annual update factors and budget neutrality factors, all those different rates. So occasionally we've had providers just ask us to send a copy of this to them. We're going to be putting this on our website. So for example, if I wanted something, a rate from 10/1/22 and on, I have to identify whether it has the quality indicator, whether it has the EHR reduction indicator. But then this is the rate I'm talking about, that locked in base rate. And it'll update it from that point up to the current year, 10/1/22. And it'll give you basically the new rate that you want. This is the rate you'll use to calculate your hospital specific payments on. And if you were to enter the PSNR DRG weight, it would tell you the actual hospital specific payment for E Part A line 48. So we're going to be putting a version of this out. The change we're going to be making, though, is it'll have a column right next to each of these update factors showing you what the reference is, what change request, what federal register. That's the piece that we'll add to it. And I'm just trying to clean it up right now. I've got a version of it that's a little clunky. It does that, but it's a little clunky looking, so I'm trying to clean it up a bit. So that's going to be out there. There will be some links to the value-based purchasing factors, quality reporting factors. All of those will be out there. Just some basic information on interim rate changes. We'll still be sending rate change letters out because there's no other way to know that information. Well, again, I shouldn't say no other way. You can find it on the CMS web pricer or the DRG inquiry screen, but we will still send those out throughout the year. And there are going to be some more miscellaneous type question and answer responses here. And then down at the bottom, even more information on how to use the pricer and grouper screens from that DDE website or DDE tool that I talked about above. So I know this is a very, very quick overview of this. Again, once I get it ready, once we get it on the website, I'll be posting a YouTube video covering all of this in more detail, and you'll see exactly what it looks like then. I just wanted to give you a heads up that that will be coming. Next topic we have is the IPPS proposed rule for fiscal year 2024. So there, obviously, with any of these proposed rules, the bulk of what that proposed rule covers is the rate development, how the wage indexes were developed, all of that. And certainly we don't go through that. We go through the things that are more applicable to the cost report side of things and the audit side of things, and some of the new things that maybe we haven't seen in the past. So one new thing that came out this year, because of the Consolidated Appropriations Act of 2021, there's a new type of hospital, a new type of provider. It's called the Rural Emergency Hospital, the REH. Now, there's a lot of information in that proposed rule about this in general, a lot more than we're going to cover here. The one piece we're going to cover, though, is the GME, eligibility for GME when the training for those interns and residents, when it occurs in one of these rural emergency hospitals. The two pieces I want to mention here, and by the way, I did add a couple of things to this PDF or this PowerPoint just this morning, so you won't see it in your current version. Basically, they're page references. If you were to go to the proposed rule and download the PDF document, this is the page number you'll find it on. But specifically, this could be allowable in two ways. If the hospital rotates the interns and residents to this rural emergency hospital, that is allowable. You can count those as part of your normal rotations. But also, if the rural emergency hospital itself incurs direct cost of providing the training, they can claim the FTEs themselves as well. That's a pretty high level overview. The Federal Register goes into a little more detail of that. And certainly all of this stuff, since it's brand new, it'll have to be incorporated into the policy manuals, the cost reporting instructions, maybe some change requests. But this is just the beginning piece of it. And again, this is the proposed rule. We will have the final rule coverage when we have one of the later webinars. So we'll go through it at that time as well. One other new change was if you have a sole community hospital that was able to get that status because they merged with another facility. So let's say, for example, that facility, those two facilities were too close previously, and that prevented the hospital from being a sole community hospital. Maybe now with the merger, now you can all of a sudden become a sole community hospital. So if that merger facilitated the status change, then now that effective date for sole community hospital status is retroactive to the date of the merger, as long as you filed the request within 90 days. So there's a little bit of information there on page 325. Another new change, this was the result of some appeals and lawsuits, but if you have an acute care hospital that reclassed to rural, they were urban and they reclassed to rural for one of many reasons. Previously, since they reclassed to rural, they were no longer considered urban and therefore could no longer be eligible for capital dish because you have to be urban to be capital dish. CMS changed that as a result of those lawsuits. And now if you were urban and you've reclassed to rural for whatever reason, you still retain your urban status for capital dish treatment itself. So that's page 401. Again, this all assumes this is finalized in August or so. The next topic I want to talk about, I'll spend a little bit more time on this one, is nursing and allied health hospitals. So for a little bit of history, a few years back, we had change request 11642 that finally updated the various factors for this nursing and allied health add-on payment. And it also updated the GME managed or Medicare Advantage managed care reduction factors. Now, the changes to the nursing and allied health side of things, that add-on payment, they generally had a negative impact for the payment, and it reduced the payment to providers. But the managed care side, for those that had GME and had Medicare Advantage utilization, that increased the total settlement for providers. So some providers had negative impact from this change request, some had positive. CR 13122, which just was recently issued, that started a second round of reopenings for those same nursing and allied health hospitals or hospitals with nursing and allied health. What I will say, though, is 13122 had no impact whatsoever on the GME side. It's only adding payment to nursing and allied health hospitals. So it basically removes the pool factor for the later years. They were limited to, it was $60 million national pool. That was eliminated. In fact, let me open that up and show you what I mean by that. So this is the end of that change request. And again, this is public. You can find this on the CMS website, change request 13122. But the only thing it changed was the pool factor for each of these years from 2010 to 2019. These used to be locked in at 60 million. If you look at 2019, now it's more than double that. So that would, in fact, more than double the nursing and allied health payment for you. It's a direct proportionate adjustment. So that's the change with CR 13122. However, the other factors that changed in CR 11642, basically these factors over here, they had a negative impact on the payment. And in some cases, actually in most cases, the change in 13122 was not enough to offset the negative change in 11642. That's the way it is. So yes, it's helping providers this year, but it's not helping as much as the 11642 reduced the payment. So that brings us to this proposed rule. There's a piece on, and that's the wrong page reference there. I don't think it's page 65. Let me find that here. I think it's 365 actually. Just one second. But it basically enhances that even further. Yes, it's 365. So right where they talk about all the different factors, the proposed factors, all of that, they go through and they reference the old CR 11642, the new 13122. There's this piece right down here that you really have to read through it a bit. Again, it's just proposed right now. We assume they'll finalize it. But basically it says we propose that the max will determine whatever the payment should be under these new rules, plus add in any amount if the amount previously recouped under 11642, a negative settlement, if there's a difference between this new amount and the old amount. In other words, if the new calculation is not enough to recover or restore the amount recouped under 11642, that additional amount will be added in right now once this is finalized, if it's finalized. So the reason I'm bringing that up here, that's definitely going to help providers that have nursing and allied health. That's only going to impact those that had a negative settlement from CR 11642. If your total settlement between GME and nursing and allied health was already positive, then that Federal Register is not going to benefit you or hurt you. It's not going to impact you at all. But if your net settlement from 11642 was negative, then once this final rule is, or once this proposed rule is finalized, that's going to change what we're doing with this current CR 13122. So we have these reopenings right now. This requirement from CR 13122 actually requires us to complete these reopenings by December 28th. The problem is this proposed rule won't be finalized until approximately mid-August. So for those providers that are going to be impacted by that, we kind of have to wait for the new rule to come out. Otherwise, we'd be doing two separate reopenings. So there are plenty of providers that are not impacted by that change because they already had a positive from 11642. We're settling those right now with the new 13122 requirements. The other ones, though, we're going to have to wait for the CMS instruction, basically finalizing that additional adjustment. It'll help you. So that's the piece I wanted to mention there. Low volume MDH extensions, I got another page for that. Really, nothing's changed. It's the same as it's been in prior years, the past few years at least. The proposed rule continues to require a written mileage attestation as well as the submission of your most recent worksheet S-3 by 9/1 of 23, September 1st. Now, the problem with this every year is that, yes, they put it in the proposed rule, but keep in mind the final rule doesn't come out till sometimes mid-August, maybe even a little bit later, and then all of a sudden the due date's just a week or two after that. We do expect this to be finalized because Congress already extended this, so there's no reason to believe something will change. So basically, you could start submitting your low volume documentation right now if you want, and you can send it to audit.advisement@wpsic.com or just to me, my personal or my individual email address. The one thing I want to point out here, though, if you've already qualified for low volume, we just need an attestation about the mileage. We don't need to see the new MapQuest or other documentation. That's only needed if you're brand new low volume, if you didn't qualify last year. The other question that comes up from time to time is the discharge data. This always has to be the most recent worksheet S-3 as of the date you submit the request. There's never an update to that. It's a locked in prospective rate. So whatever your discharges were on that S-3, that's what's going to be used for the entire year. Even if it's a short or long period, we went to CMS on this a few years ago and got clarification that the Federal Register, as it's written right now, it makes no distinction between a standard 12-month or a short or a long period. There's no proration or annualization calculation included. So whatever your discharges are, that's what's going to be used for the calculation of the low volume. And yes, that's just, you don't have to send anything in whatsoever for MDH, assuming you're already qualified for MDH. The annual thing is just low volume. So we have that. And again, you'll want to send those in. What I usually do as we get closer to that date, I take a look at what providers have not sent them in, and I gather the most recent uh, email information we have from the prior year, and I send out a reminder because we definitely want providers to get this in on time. Because if it's not submitted by 9/1, then the effective date of that low volume is 30 days after we complete the approval, which means there's going to be a gap somewhere there. Might be a few days, might be a few weeks where you don't qualify for low volume. So definitely you want to get this in by 9/1. That's the point I'll make there. And back to the other question here. Oh, yeah, David, very good question there. Do we expect the pool amount to revert back to the prior established cap? And the answer there is right now, yes, it absolutely will. Let me open up that CR again. Or actually well, yeah, I'll open up the CR because that incorporated the change. The legislation, uh, Section 4143 of that Consolidated Appropriations Act, only revised it through 2019. Now, of course, there's always the potential that Congress will come out again and extend that through 20, 21, 22, and on. But right now they haven't, and CMS themselves would not have the ability to do that because that is a statutory pool amount. So it would have to come from Congress if they wanted to extend it further. So for 20 and on, we're right back to the 60 million pool. And again, that's beyond CMS's authority to do anything about. So good question there. Let's see. Now we go on to the dish topic, which there's a lot of information here. I'm going to try my best to consolidate it and make it an intelligent discussion in the short period of time we have to cover it. But basically, the dish issues that have been around for a long time, over a decade now, they deal with two different things we're going to talk about: the SSI ratios, and then now a fairly new one, the dish Medicaid days, specifically the Section 1115 waiver days. So there are many pending issues related to SSI that have been around for years, including all the way back to the Bay State cases with matching. We're not going to go through that. That's pretty much been settled and locked in now. But when we're calculating DISH, we have two different ratios that are important: the SSI ratio, or the Medicare fraction, and the Medicaid ratio. The calculation of the SSI ratio is, the numerator is patients that are entitled to both Medicare Part A and SSI. Now, the key word there, I should have bolded it, is entitled to Medicare Part A, divided by all patients that are entitled to Medicare Part A. So obviously the difference here would be whether or not they were entitled to SSI. That's the difference between the numerator and denominator. So the question has always been, well, what about Medicare Part C days, or even exhausted benefit days, where they were Medicare Part A, they were entitled to it initially, but now they're just not covered by Medicare Part A, either because they're now covered by Part C, or they've exhausted benefits for that stay, for that year, whatever. The rule now, and now it's been settled, or at least for the most part, is that the patient still retains that entitlement to Medicare Part A, even though they're not currently paid under Medicare Part A. They're still entitled, and that's what the legislation in statute requires. Or I should say the statute itself. So that's what we're going to focus on there. The Medicaid ratio would be those patients that are eligible for Medicaid, but they're not entitled to Medicare Part A, because if they are, we want them up in the SSI ratio instead. So Medicaid patients divided by total patient days. Obviously, these two fractions have completely different numerators, so it's not like they're just different things altogether. It's just the way the calculation was built. But if CMS had not made the change they did, and if the exhausted benefit days, and actually this should be Medicare Part C is what I meant here, if those were not included in the SSI ratio, if the courts had gone a different way, then assumedly they would go here instead, because they would no longer be considered Medicare Part A entitled. But again, that's more of a what if, what could have happened. That's not what we're doing now. Section 1115 waiver days, they're technically not full Medicaid. They're not the same Medicaid. We don't get the RA or anything like that, but they are now to be included in the Medicaid ratio. And that's the second topic we'll talk about. So let's briefly go through the history here. Discharges and the reason I'm going through the history, by the way, is that this is very applicable right now to a lot of reopenings we have. Many of you providers are already aware of a lot of those things that have been on hold for quite some time. So discharges prior to 10/1/2004, at that point, only the covered days initially were included in the SSI Medicare ratio, and everything else was considered in the Medicaid ratio. So regardless of entitlement, coverage at the time was what mattered. When these rules first came out, there was really no discussion of Medicare Part C. The early discussions talked about the non-covered days because they exhausted benefits. So the first time this issue was addressed, this entitlement issue, was in CMS ruling 1498 R2. But even that only impacted the exhausted benefits days. And we refer to that as kind of the total versus covered issue. That ruling basically said that yes, those days, since they're still entitled, they could be allowed as Medicare. It explicitly left Medicare Part C untouched, or I shouldn't say explicitly, it just was untouched. They didn't address that. CR 9311, change request 9311, and then 10487 came out to incorporate or implement this 1498 R2. It brought in this total versus covered election, which basically gave providers the option to choose whichever rule they wanted to use for these pre-10/1/2004 discharges, because there was really no good rule in place at the time, so they gave them the option. A little bit later on, CMS also brought in the ability for them to request a realignment at the same time. So 10487, which is the latest of those change requests, basically brought in both elections that a provider could make. That was basically, it was kind of informally put on hold because of the fact that there's still that case out there, the Alina case, that brought to question how do we handle the Medicare SSI ratios, which would come into play with an SSI realignment. Or really, even if you didn't realign, we just don't know what SSI ratio to use. It was under appeal, under court. So that was contested. So 10487 was kind of informally put on hold there. And we'll get back to that in just a bit. Moving on to the discharges from 10/1/04 through 9/30/13, this is where a lot of the cases came from, a lot of the appeals and such. We had the fiscal year 2004 proposed rule that basically, in that proposed rule, CMS said, hey, we think the Medicare Part C days should go in the Medicaid ratio. They were still focused on entitlement at that time. But then in the 2005 final rule, well, let me back up. In the proposed rule, the other thing they talked about was removing the coverage requirement. So they initially thought the exhausted benefit days should also go in the Medicaid ratio. That was what they proposed in 2004. but there was very clear public comment that persuaded them otherwise for those exhausted benefit days. And in the final rule, they said, we agree exhausted benefit days should go in the Medicare SSI ratio. They basically removed the coverage requirement from what goes in the SSI ratio. It's now focused on entitlement. So they proposed also to include the Medicare Part C days in the Medicaid ratio, and then they reversed course to finalize them in the Medicare SSI ratio. And you could see that this coverage issue covers both of these things, exhausted benefits or SSI ratio. So CMS finalized the Part C days to be treated the same way the exhausted benefit days were. But because of the lack of public comment about that issue, there was an argument in the Alina case, in one of the Alina cases, as to whether that was truly a logical outgrowth of the proposed rule. So basically that was contested at that point in time. And any settlement that was still reopenable at that point in time from prior to 10-113 had a notice of reopening issued to protect the reopening rights, just in case the courts held against CMS or found against CMS. Multiple rounds of those cases. We don't need to go into great detail on those. But then in 2019, there was an Alina Supreme Court decision, a later one finally, where the court agreed that CMS made an error in how they handled that final rule. They should have really issued another proposed rule and then proposed the new thing they were thinking, that put them in the Medicare SSI ratio, but they didn't. So the Supreme Court basically remanded this back to them to handle it properly through a new notice and comment rulemaking. So they did that shortly after, I guess the next year, 8/6/2020, they issued a proposed rule focused on Part C days, and they handled this through retroactive rulemaking, which they tried to support in that proposed rule. They basically said, because of all these discussions, because of the whole coverage versus entitlement, we believe that the Part C days should be in the Medicare ratio, as they are 10-113 and after, which we'll get to in the next slide. There's already been a proper rule for 10-113 and after. So they wanted to handle these consistently after the Supreme Court said, hey, you need to figure out how to fix this through notice and comment rulemaking. They did so, but they did it retroactively. That was proposed rule. The final rule was actually just issued a few days ago, last week. But in the meantime, there was another Supreme Court case in 2022 that reinforced how CMS is handling the exhausted benefit days, including them in the SSI ratio. They basically strengthened that phrase, entitled to Medicare Part A, and they said that, yes, they're still entitled even though they're not covered. That case absolutely did not address Medicare Part C specifically, but it's the same essential issue of entitlement versus coverage. So that, this is just a little bit more information about that. The Supreme Court sided with CMS on that. So exhausted benefit days are included in the Medicare SSI ratio. Here's a little bit of information about the Ninth Circuit. Initially, they sided with those particular providers about including exhausted benefit days in the Medicaid ratio instead of the Medicare ratio. But after the Supreme Court decision, that was moot. Now, exhausted benefit days are in the Medicare SSI ratio. Now we have the final rule that just came out of the Ninth for Part C days, still retroactive rulemaking, any unit that is still open. And basically that said, it also brought in that Empire Supreme Court case as kind of more ammunition, if you will. So the rule is now that Part C days, as well as exhausted benefit days, are both included in the Medicare SSI ratio, which is consistent with how they're currently being treated 10-113 and after. That was in the fiscal year 2014 final IPPS rule, where they said the same thing for those later discharges. So a lot of information there. The point is that both of those really for all applicable years are now in the SSI ratio and not in the Medicaid ratio. So what does this mean for us? What does this mean for providers, MACs, everybody? First of all, the very important thing to note is that it means nothing until CMS issues a change request. No matter what you find in the Federal Register, CMS still has to implement that through a change request. We don't know when that's going to come. We don't know exactly what it's going to say, but here are the things that will impact. The first thing is that all those CR 10487 project reopenings, we expect those to start rolling again at some point because now the rule is there that the SSI ratio must include exhausted benefit and Medicare Part C days. These were all prior to 9/30/04. That's what this CR was about. There are quite a few other older SSI realignments prior to 10/1/13. And again, for the same reason, we expect that now CMS knows the rule. We expect that those will be issued at some point, or at least they can issue those now. And all those reopening letters for the Alina case that were kind of preventative or just in case from 10/1/04 through 9/30/13, because the SSI ratio is no longer going to change, it had the exhausted benefit in Part C days all along, and there's no reason for it to change. These might be closed. We kind of expect that CMS will require us to close those reopening letters. So what I want to point out, though, back to these first two things, you can imagine that's a lot of workload there. All of that is being done at the same time that this nursing and allied health reopening project is being done, and we have several, quite a few hundred of those to do at the same time with a very short time frame. So we're not sure, and again, all other MACs are impacted by this as well. We're not sure how CMS is going to fit all these things together, what the timeframes are going to be. But I just wanted to mention, don't expect that this will be immediate. Even if CMS starts this right away, it will have to be phased in, or not phased in, but it'll have to be kind of gradually taken care of. So this is all coming from me. This is not from CMS. We do not have any final thing from CMS on this. Just wanted to point that out. Brian, that's a good point. CMS has taken down the SSI ratios from the portal. I did not notice that recently. So I bet you this is the reason. They're probably adding some additional verbiage out there, but I had not noticed that. So I don't know when they'll make those available. It might be when the CR comes out. That might be what they're planning there. So thanks for pointing that out. I'll have to take a look at that. Prohibited reopening. So what I wanted to throw this in here, it actually impacts a few different things, but it's something CMS SSI ratio issues. Keep in mind, most of these were already reopened kind of preemptively, but basically no new reopening can take place for this issue solely. And it'll come up again in another issue I'll talk about in just a bit. The next topic I have here is the Medicaid ratio. The only thing we're really focusing on here is this change request 12669 that was issued back in March. Here's the link to it. And it's for those Section 1115 waiver days, specifically in those states that have a low income pool method for these days, or an option, if you will. This new treatment that basically requires MACs to allow this, at least temporarily. There's a proposed rule that's trying to reverse that, but temporarily these days are allowed for these older years, but they're only allowed for open cost. The key thing is we're not allowed to reopen a regular reopening to include new Section 1115 waiver days. And that same prohibited reopening verbiage that I mentioned is why. So this has been stressed to us by CMS as well. Now, for those that are still open, you can amend the cost report to include new Section 1115 waiver days, as well as other issues up to the point the desk review or audit began. After that point, after the desk review or audit has started, you're only able to include 1115 waiver days themselves. Now, obviously, the other thing you could always include would be the regular Medicaid days. You have a year to include amendments for that. That's been in place for a number of years now. The key thing I want to point out, though, is that you must include the support for those days, and it must be in a separate log. So have this separately, these 1115 waiver days, separate from your traditional Medicaid days. And the reason is the documentation and the review is significantly different than a regular Medicaid day that we would have an RA for, Medicaid RA for. The 1115 waiver days, those are often supported by state-only documentation that's outside of or I shouldn't say state. You maintain documentation. Again, each state is going to differ what they have, but it's not generally going to be in a formal Medicaid RA format. So it's a different review. And what I want to say here is that earlier submission is better. We want this as soon as possible, rather than waiting until the desk review is virtually completed and the adjustments have been sent out. We'd prefer to get it at, a perfect time would be at or before the beginning of the desk review or audit. So just wanted to mention that, because again, once this has been NPR'd, we cannot reopen for that issue. Next topic I wanted to talk about here is the Hershey case, and that's just a general term for this one, the Hershey decision. But there was a dispute with how the FTE counts were being handled when the provider was above the FTE cap and they had fellows, in other words, interns outside of the initial residency period that were trained. And the argument, which really was a very good argument, was that there was a penalty in the calculation when you had these interns and residents beyond the initial residency period and you were over the cap. There was a different treatment. There was essentially a penalty built into the calculation. Probably not intentionally, but certainly it had an effect. That was the argument. So I'm going to just show one of these examples. I want to make sure we can cover all of our additional information. But let's look at scenario one, where the provider has a cap of 100 and they're at or below that cap. In other words, they're not above it. They had 90 regular residents and 10 fellows, which were beyond the initial residency period. Therefore, they're weighted at 0.5, 50%. They don't get the full FTE for that. In that case, since they were below the cap, you'd have a total of 90 FTEs, but it would be multiplied by 90 plus 5, half of the fellows, basically. So times 95, you'd get your full 95 there. Scenario two, same basic thing, except now there are additional fellows that are beyond that residency period. Therefore, the FTEs in total are above 100. So you have 90 residents, 20 fellows. So you have 100 divided by 110, the 90 plus the 20, but they only get multiplied by 100, 90 plus half of this 20. So the problem is the resultant FTE allowable count is 90.91, which is less than what you had before, just because you added additional fellows. That really made no logical sense. That why would they be penalized? At worst, they should have 95. And basically, there's no reason the count should have decreased. That was an example of the argument that was successful. And because of that, the 2023 final rule implemented this decision, and all settlements were held. As soon as that final rule was issued, we were required to hold all settlements until we could incorporate that change. HFS made changes to the cost reporting software. They made some temporary changes, and then they made some final changes when Transmittal 18 was issued. Basically, this impacts Worksheet E-4 line 9, 12, and 13. Here's a listing of the revised calculation, but basically they split, they split the treatment of the unweighted versus the weighted, so they weren't merged together into that weird calculation. So the result is that penalty is now gone. There is no penalty for that, for having additional fellows above the cap. You're still only going to get weighted at 50%, but there's no penalty. So HFS initially updated the software with Mac only changes so that we could actually move forward and settle the cost reports properly. Those were on E-4 line 109, but Transmittal 18 issued by CMS formally changed this. And now if you look at the instructions in E-4 lines 9, 12, and 13, you'll see that verbiage built in. Now here's the piece that I wanted to add. It's a little unusual how CMS did that with the cost reporting instructions. On S-2 line 68, there's a control question that basically turns on this new Hershey treatment. It's a yes or no, and it's only applicable for cost reports beginning before 10/1/22, because after that it's locked in anyways. So what CMS basically said is they said you have to obtain permission from the Mac to use this, which is odd because there's really no review protocol for it. When we've worked with CMS, basically they said their purpose for that was to make sure that it was not, you won't turn it on when you submit an amendment, but the benefit will still be incorporated at final settlement. We are required when we settle these to incorporate that new treatment. For original cost reports, though, which again, if you happen to still have one that you're submitting beginning prior to 10/1/22, then that whole permission thing comes into play. Basically, you don't necessarily need to get an email from us. I know we've had a lot of providers requesting emails just for documentation. You can use this slide if you want to for permission, or we're also going to be updating our website that basically says the same thing, that you can use the website as quote unquote permission. But if you feel more comfortable getting an email, that's fine as well. Just kind of odd how CMS put that in there. And yes, the answer, yeah, all GME providers that are actually impacted by it. Some of them won't be impacted by this at all because they didn't exceed the cap or they didn't have any of those fellows, so the treatment won't matter. But yes, if they did have this, then it does need to be a yes. Now again, for that situation, we can't do it through a reopening. All future cost reports are settled with the new calculation, and obviously if it's part of an appeal, it can be revised. And let's see, I want to take a look at the questions here before we get into our final piece here. Let's see, we have, will Max implement the new treatment when if contractor initiated reviews take place for items like nursing and allied health? So this piece cannot be reopened, even if it's reopened for like a nursing and allied health reopening. Or if you submitted a bad debt reopening later on for one of those older years, we would not be able to turn that GME treatment on, unfortunately. And it all goes back to that prohibited reopening verbiage. That's what CMS is centering that decision on. So let's see. I think we have all the questions answered up to this point. So now we have about 15 minutes left, and I just wanted to run through some of the resources we have, some of the things we're going to be putting out there, and of course, we still have time for any questions that providers or anybody may ask. But on our website, this first link I have here takes you just to our audit portal that has all the audit topics. This next link is to our YouTube audit playlist. Now, again, we have other areas of the company that have YouTube videos for claims and provider. Now, the next few slides, I'm not going to go through in great detail because I've copied these same slides for the past few webinars, and this is just a history of the YouTube videos we've created from 2019 all the way on. So it's informational only. You can see some in 2020, 21. This includes, by the way, the recordings for the various webinars. So all the way on to the EHR payment reductions, 21. Scrolling forward a little bit more. The relatively new ones since the last time we talked, we have a swing bed sniff NIF rate that we created for the acute and critical access hospitals. This video goes through that calculation, goes through the cost report flow. We had our S10 webinar from March that we've linked here. And then we have the 3 templates that we've added in that, again, we talked about them a little bit in this webinar, but here is the YouTube video that goes into much more detail. Here you can see the S10 is 46 minutes because it's really covering 3 templates by itself. The DISH Medicaid eligible days is 22 minutes, and the Medicare bad debt template review is 28. Now, some of the YouTube videos I have planned for the future, there's one that's been sitting out there I've been working on. It's also going to be a website update, basically talking about some of the general things, that information we may be requesting at desk review or audit. And really, it allows you to prepare for some of that. You might even submit some of that early. But I just wanted to go through. Obviously, we can't give away full-blown desk review or audit protocol, thresholds and things like that. But we can give away some of the types of information we would need for various types of reviews. So it'll instead of you being surprised by a MAC request, an auditor request, it'll just give you a heads up. That's what this video and that website will be related to. There's another topic that I really want to get out as soon as I can, but we're basically waiting on CMS clarification for some of this. It actually deals with RHCs from 2 angles. The new rate settlement required, again, under that Consolidated Appropriations Act, the rates have changed significantly. And then that also, because of the rate changes, that impacts the consolidation requirements, or consolidation options, I should say. We have a couple of what we call technical direction requests we've sent out to CMS, and we're waiting to hear back on that so we can put something out to communicate it to providers and everybody else. A brand new thing we have out there, or not out there yet, we want to put out there, but it's related to the brand new Home Office 287 22 cost statement forms. These are new forms. There's a new electronic requirement for this, but I want to put a YouTube video and a website out there related to that. And then, as I mentioned earlier, once I get that mock-up ready to go for the website for that provider claim and rate website, I want to put a YouTube video out there as well. So those are the 4 you should expect in the near future, the next couple of months, few months. There might even be other ones out there as well. We have webinars. This is just our history of the webinars since we started back in October of 2020. Some of them are S10 specific, including the one in February, and obviously June, that's today. And that takes us to the end of what I had for the webinar. One thing I did want to point out, we do have a survey that's available under one of two different options. You can either scan this code or click this link to complete the survey. We certainly appreciate any feedback you could provide. Sometimes that might be feedback on this particular webinar. In other cases, it may be suggestions for other topics to cover. Keep in mind, we do plan on doing these about once every 3 months approximately, so almost quarterly. And any feedback we get, we'll certainly incorporate that in there. But at this point, I'll open it up to see if there are any remaining questions. We do have 10 minutes before the hour. It's given us some time for questions. I know I usually go right up to that last minute or two. So any questions, any final questions anybody has before we end? Okay, well then just wanted to say thank you again. I will be sending an email out here in the next couple of days with everything that I talked about up to this point. The agenda, the PowerPoints, all of that stuff. So thanks again. I hope everybody has a great afternoon and great rest of the week. I will talk to you in the next webinar in a few months.
Thank you.
All right, thank you.